Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I'll be discussing with you the management of diabetes for a patient who is on metformin and the hemoglobin A1C target is not achieved. The target should be personalized. Depends upon the comorbidities, the expectations of the patient, age of the patient, etc. The targets are different, but usually we aim to achieve a hemoglobin A1C of 7 to 8% in most patients. So here it is well above it. So we have to add on another drug. What is already known about this? We all know that metformin is the initial therapy in most patients with type 2 diabetes unless there are no specific contraindications. The optimal choice of the second drug is not well defined, and so there are lot of practice variations. And the number of studies comparing sulfonylureas with other drugs as add-on to metformin is less. So I have selected an article and we will discuss what is new and what the various guidelines say. So here is the article, Safety of add-on sulfonylurea in patients with type 2 diabetes using metformin. This came in BMJ Open 2021. So this is a stroke diagram. The patient select included more than 36,000 cases and finally analyzed 32,576 patients. There are two groups. One on metformin plus sulfonylurea, which included 28,077 patients, and other group is metformin plus other OHA, that is OHA other than sulfonylurea, 4,499. So significant number was there. They found that the all-cause mortality, the hazard ratio was 1.44 for those on sulfonylurea, and statistically significant. Major hypoglycemia was a very important complication. The hazard ratio was 2.78. And there was no significant difference in cardiovascular events. The hazard ratio 0.99. So this shows that the sulfonylureas versus other OHAs were having no significant cardiovascular events. But later, the post hoc analysis, they found that the newer OHAs, that is, after 2008, lot of newer drugs came, and OHAs other than sulfonylureas were added to metformin, and in such cases, the cardiovascular risk was less. So this added to the controversy already existing. And let us see what is the 2022 guideline ADA says. The ADA says the first line therapy for diabetes depend on comorbidities and it should be a patient-centered approach. So whether the patient is having obesity, whether he is having cardiac disease, whether he has got a heart failure, whether he has got a CKD, and these are major confounders for starting therapy. And metformin and comprehensive lifestyle modification still remains the first choice. So any patient with diabetes, if no contraindications for metformin, start on lifestyle modification plus metformin. And regarding the second add-on drug, there are two schools of thought. One, in all patients with type 2 diabetes, sulfonylureas are harmful. Again, the previous study which I quoted suggests that the cardiovascular events are more in patients on sulfonylurea when added to metformin. The other groups feels that still there is a place for sulfonylurea and it should be continued, especially because of the low cost and effectiveness, and many of the recent trials have exonerated sulfonylurea. So these are two schools of thought. And why the cardiac safety concern for sulfonylurea? We know that the sulfonylurea act by blocking the ATP sensitive potassium channel. So this is a potassium channel and the ATP can block it, and to which the sulfonylurea attaches. So once the sulfonylurea attaches there, it closes the potassium channel KR 6.2, and what happens? The potassium shifting to outside is blocked. So the membrane gets partially depolarized. That opens up the calcium channel, voltage gated calcium channel. So calcium enters the cell and it produces exocytosis of the insulin, and thus the insulin is released from the beta cells. The problem with the sulfonylurea receptase is that it is present in other tissues also. There are mainly two types, SIR1 and SIR2. Sulfonylurea receptor 2 is the predominant one present on cardiac muscles. The SIR2 is again divided into A and B. It is A which is present in cardiac muscles. It is because of the attachment of the sulfonylurea receptors to the muscle, the cardiac muscles, that may be the reason for the increased cardiac events. So this may lead on to the many problems, especially following myocardial infarction, the induced arrhythmias, and different mechanisms are there. So that is the main safety concern. But it has been found that the sulfonylurea has got a different affinity. Various sulfonylureas has got different affinity for these receptors. For example, glimepiride has got less affinity for this cardiac SIR2. So that may be the reason why the sulfonylureas are comparatively devoid of the cardiac events associated with the older generation sulfonylureas. Now we look at the various studies. We can see that the initial studies have given concern related to the development of cardiac events, but the advanced trial, the cardiovascular safety of glycoside was demonstrated. So they have found that it is not only that it is not harmful, it has got a safety profile, glycoside. Later, the Carolina trial has found that the glimepiride is devoid of much cardiac events. So these two major studies states that sulfonylureas has got still a place in the management. Let us look into the ICMR guideline. The ICMR says when a patient has got diabetes, start with lifestyle modification for all patients, and the hemoglobin A1C is less than 9, monotherapy with metformin. If hemoglobin A1C is more than 9 and patient is symptomatic, consider insulin. Symptoms means osmotic symptoms, that is weight loss, the significant polyuria and catabolic features like weight loss. Then you start on insulin. If there are not much symptoms or symptoms and signs of catabolism, you may consider dual therapy at the beginning of diabetes treatment. So you can start with monotherapy with metformin and look for the target hemoglobin A1C for the blood sugar values. It is not a target, you go for dual therapy. In dual therapy, as per ICMR guideline, the first choice will be sulfonylurea. We can use a DPP4 inhibitor or SGLT2 inhibitor. The second choice add-on therapy is alpha glucosidase inhibitor, the meglitinides and thiazolidinedione. So any of the drugs can be used. So let us look into the state guideline. The DHS guideline in Kerala, again almost in uniformity, start with metformin, start with the smaller dose, start with the 500 milligram, especially after food, then gradually step it up to 1000 milligram PD. And the patient is not responding, you add the dual therapy, start with the glimepiride 1 milligram and gradually step it up. So in most of the guidelines, the first drug is metformin, followed by the first choice sulfonylurea, or depending upon the patient characteristics, and availability, you may go for DPP-4 or SGLT2. Now going to the 2022 ADA guideline. In the ADA guideline, again, it is a patient-centric approach. First, we look at whether the patient is having atherosclerotic cardiovascular disease or they are at high risk. High risk means more than 10%, the risk score is there. Second, look for whether the patient has got a heart failure. Third, you look for whether the patient has got a CKD. If any of these things are not there, the treatment depends upon other patient characteristics. The first characteristic you look for is whether the patient has got increased risk of hypoglycemia, whether you have to minimize the hypoglycemia. For example, a patient with an elderly patient, they are at risk of hypoglycemia, so you may select a drug which has got less propensity to produce hypoglycemia. And weight gain is an important problem, and if the patient is obese, BMI is high, you may select a drug which can decrease the weight. And third is the most important thing that we will consider is the cost of therapy and the access. Even though ADA says if the patient has got you can use SGLT2 or GLP receptor agonist, in our place it is a very costly thing. So I personally feel the sulfonylurea has got a major role to play in our place even now. And if the patient has got a high risk category, that is cardiac disease, heart failure, CKD, the choice will be either or in combination with metformin. You can use SGLT2 inhibitor, GLP-1 receptor agonist. This can be used alone or both can be given in combination with the metformin also. The patient is having heart failure, obviously the drug of choice will be SGLT2 inhibitor. And in patients with the CKD, again, depends upon the proteinuria and other features, you may select one GLP receptor agonist or SGLT2 one inhibitor. So this is the broad outline of the guideline. And again, as I already mentioned, even though the ADA is recommending or promoting the use of newer drugs, in economically weaker areas, still sulfonylurea has got a major role. So in this session, we have discussed about how to select the drugs, how to initiate treatment, what should be the first drug, and when to add a second drug, and what are the choice of second drugs. So in short, I can say, even though sulfonylureas are going out, but the number of prescriptions are coming down, and the newer drugs are becoming more popular, prescriptions are increasing, still sulfonylurea has got a role in management of type 2 diabetes, especially as an add-on therapy. Hope this was beneficial to you. We'll come with another topic in the next session. Thank you.